Starting now. Start another transition. Okay. Last ఇక్కడ వరకు పెట్టాను. Okay. Yeah, okay. Thanks to the CR. I mean, he has at least timely informed me that it has stopped streaming. Otherwise, the whole effort would have gone in waste. Now, coming on to the requirement, I think it stopped streaming from here. Let me check. Fine. Okay. Okay, so I was talking where I think it is that this particular slide I had got the streaming got stopped. Now the requirement here was around 23 ml per minute. The first year it is 78 ml, fifth year it is 100, 10th year it is 175 ml, the adult is 240 ml, and in the female it is 200 ml per minute. Now there is a variation here with as the age advances you will see that the requirement of the oxygen goes up, and once this oxygen requirement is increasing because the body surface area is also increasing. One thing you need to find out from your side is why is this requirement in an adult 240 per ml per minute more than the requirement in the female. Now let's go on to the next slide here. Variations. Now anyhow I will repeat some part. I don't know whether that was displayed or streamed or not. I will just repeat that 2 minutes thing which is there. Now see the requirements. You actually go and correlate the three things I have told you: the respiratory rate, the tidal volume, and the requirements. If you see the requirement here, in an adult male, to supply 240 ml of oxygen per minute, the person has to have a tidal volume of 500 ml with a respiratory rate of 12 to 15 per minute. So assuming that he is breathing at around 240 to 50 ml per minute, 12 times in it, the requirement is around 240 ml per minute, the tidal volume is 500 ml, and the respiratory rate is 12. The alveolar ventilation is at 6 liters per minute. So to supply or to provide 240 ml of oxygen to the cells, there has to be alveolar ventilation of 6 liters per minute. Similarly, in a child, you see the 23 ml per minute is the oxygen requirement. The child is having a very less surface area, so the oxygen requirement is less, and that requirement is around 20 ml. Let's say around 20 ml per minute. Now, to supply that 20 ml per minute, the respiratory rate has to be around 40 ml per minute. The respiratory rate has to be 30-40 per minute, and with a tidal volume of 10 to 20 ml. So this is the thing. If the child is having a tidal volume of 10 or 20 ml with a respiratory of 40 ml, that means 800 ml is the alveolar ventilation, and if the child breathes with the alveolar ventilation of 800 ml per minute, then the oxygen supplied to the tissue is around 23 ml per minute. Then the normal physiological processes are going on. Similarly, there can be instances where the requirements can be increased because of physiological needs or because of some pathological conditions. The oxygen supply may not be at around 240 ml per minute. For physiological examples, I will give you the example of an exercise. Now, when you do an exercise, when you are exercising, let us say a short exercise or a long distance running, whatever may be the mode of the exercise, you will find that two different things are happening. First, the depth of the breathing is increasing. So you take in air more deeply. So the tidal volume is increasing. When the person is breathing more air with more depth, that means the amount of air which is going in and out is increased. So that means the tidal volume is increased. Plus, the number of times the person is breathing is also increased. So when the number of times the person is breathing gets increased, that means the respiratory rate is increased. So suppose let us say that the tidal volume during exercise, the tidal volume increases from around 500 ml to, which is normal, to around 1000 ml. So during each inspiration and expiration, 1000 ml of air is taken in and taken out. So that is around 1000 ml with each respiratory cycle. The respiratory rate also increases from a normal, let's say 12 to 20, 15, it increases to 30 per minute. So he is breathing during exercise 30 times in a minute, and with each breathing or each respiratory cycle, 1000 ml is taken in. So that is, you multiply this 1000 multiplied by 25 or multiplied by 30 times if he is breathing. So you see that it is 30 liters. So what was the alveolar ventilation at 6 liters per minute? Everything getting doubled up will provide around 20 to 30 liters of oxygen to the body. So that much amount of oxygen is supplied, then he can sustain or continue to do that particular exercise. So this is about the physiological increased requirement of oxygen by the body during exercise, and that increased requirement is provided by either increasing the respiratory rate or by increasing the tidal volume, or by both increasing the tidal volume and increasing the respiratory rate. Now, this is about, I have spoken about a physiological condition, which is a normal condition. There can be conditions where there may be a diseased conditions where the oxygen transfer may not be happening adequately. For example, in smokers, what happens in smoker? People who are in chronic smoke, because of the nicotine effect, the alveolar membrane gets damaged. Now, what was an alveolar membrane? A normal respiratory membrane which will allow the transfer to gases to take place. Because of the injurious effects of the damaging effects of smoking, this transfer of gases will not take place. Oxygen is there in the alveoli, but it is not getting transported into the circulatory system. So that means when it is not getting transported normally, there is less oxygen going into the tissues. So the requirement of around 240 ml per minute is not met. So now what the body will try to do? It will try to increase the respiratory rate. So you will find that normally the people who are smokers will be little breathless. Similarly, the condition is pathological is in asthmatics. In asthmatics also, they have difficulty in breathing air because the alveoli are in spasm. They do not allow the entry of air sufficiently. So less oxygen or less air in the alveoli. So less transfer of oxygen. So to compensate for that, they are hyperventilating. They are in breathing difficulty. They are in respiratory distress. Their respiratory rate gets increased. So that with increase in the respiratory rate, at least sufficient amount of oxygen per minute is entering into the alveoli and the oxygen requirements are met. Now let us see the next slide. What are the variations? The variations, if you find that here the respiratory rate is increased during excitement, emotions and exercise. These are the three physiological variations. Exercise, I have told you just now how the increased respiratory rate helps in providing increased oxygen to the exercising muscles. Emotions and excitement are all sympathetic effects, where because of certain emotional disturbance, or when you get angry or when you are very happy and excited, you will find that there is an increased sympathetic stimulation, and increased sympathetic stimulation will increase the respiratory rate. Similarly, BMR. This BMR, whenever there is an increased BMR, you will find the respiratory rate is increased. And what is BMR? BMR is basal metabolic rate. When the basal metabolic rate is increased, that means the activity or the rate of metabolism of all the cells in the body is increased, that means the oxygen requirement is increased. And when the oxygen requirement is increased by the cells, that has to be brought by the increase in the respiratory rate. So if the cells or the end users or the end cells need an increased oxygen, that increased oxygen requirement has to come from the alveoli, and that has to come by means of increasing the respiratory rate per minute. So an increase in the BMR will cause an increase in the respiratory rate. One example or one endocrine disorder where you find that the BMR is increased. Go back to your, after the class is over, read your endocrines. There is one BMR, there is one condition or one endocrine gland where there is an increased BMR if the glands hypersecretes. So that will cause an increase in the respiratory rate. Go and find out for yourself which hormone is responsible and which condition, in which condition will you find, which endocrine condition you will find that there is an increased BMR leading to an increased respiratory rate. Similarly, fever. In fever also you will find that there is an increased respiratory rate. If you have observed anybody at home when their temperature increases from 98.6, which is the normal temperature, to 100, 101, you will find that there is an increase in the respiratory rate. So why there is an increase in the respiratory rate in fever? This is also linked with the BMR. In fever, the basal metabolic rate is increased. If you know that, if you remember your earlier classes in biochemistry or in your class 12, basal metabolic rate is optimally working, or the cells are optimally working at a given temperature scale. Let's say at a normal temperature up to 98.6 degrees. Any 1 degree centigrade increase in the body temperature will increase the enzymatic activity, will increase the metabolic activity of the cells. When the metabolic activity of the cells is increased, that means that the oxygen requirement is increased. So when the oxygen requirement is increased by the cells, this has to be provided to the cells by the respiratory system, and the respiratory system responds by increasing the respiratory rate, so that increased oxygen is going from the alveoli into the cells. So in fever you will find that there is an increase in the respiratory rate. Similar is the opposite effect. If you have hypothermia means decrease in the body temperature, and this is sometimes used for a person's medically also to slow down the metabolic rate. If you reduce the temperature of the body, let's say from 98.6 degrees you reduce it to 85, 86, you are reducing the basal metabolic rate. When the basal metabolic rate is reduced, because if the temperature is lowered, the cell enzymatic activity is lowered. When the cell activity, enzymatic activity is lowered, the oxygen requirement is lowered. When the oxygen requirement is lowered, so there is a decrease in the transfer of oxygen from the alveoli to the ultimate cell. So this will increase or will decrease the respiratory rate. So increased respiratory rate seen in high fever. In hypothermia, the respiratory rate is decreased. Again, defective variation. I have given you 2 examples of defective variations. One example is smokers, I have told you, where there is, because of the smoking effects of nicotine or the smoke, the chemical in the smoke, it causes the damage to the alveoli and it causes defective transfer of oxygen. Oxygen is present in the alveoli, but it is not getting transferred from the alveoli into the circulatory system. So less oxygen is reaching the tissues. So there is a defective aeration or hypoxia. The other condition would be, as I told you in the earlier slide, was bronchial asthma. And in latest, if you correlate, you would have also seen that in this pandemic, the viral pneumonia oxygen requirement was there. Many people complaining of increased oxygen requirement. What is happening in this viral pneumonia or this COVID pneumonia? The COVID pneumonia is damaging the alveolar membranes, and when they damage the alveolar membrane, instead of the elastic membrane or the respiratory membrane, the elastic and the collagen, you find that it is converted into a gel-like structure where water deposition was taking place, a gel was taking place, was getting formed in the alveolar membrane. So instead of the elasticity of the alveolar membrane or the respiratory membrane, if there is a thickened membrane or a gel-like membrane, it will not allow the oxygen to travel from the alveoli into the circulatory system. So though oxygen is in the alveoli, it is not getting transferred. This leads to a reduction in the oxygen supply in the cells, which causes hypoxia, and that hypoxia has to be corrected by supplementing with oxygen, outside oxygen, through oxygen mask. So how do you supplement that? When you give oxygen by a cylinder, you give it at a high pressure, 8 to 10 liters per minute. When you supply that much of oxygen under so much of high pressure, so there is more oxygen because of the high pressure gets transferred. So instead of 6 liters per minute, you may have 5 liters of it getting transferred from the alveoli with high pressure. So at least some amount of oxygen is getting transferred because of the high pressure oxygen provided to the cylinders and the hypoxia getting corrected. So this was the reason for the increased oxygen requirement in COVID pneumonias. Let us go to the next slide. Next we will be seeing about the decreased rate. Now where do you find that the respiratory rate is decreased? The respiratory decrease rate is decreased. This opium is actually a drug. When you take drugs like opium or barbiturates is not a drug, but it is an anesthetic drug. You will find that it decreases the respiratory rate. Also during deep sleep, you will find that the respiratory rate is decreased because sleep as such causes a slowing down of all the systems of the body. Let it be the respiratory system, the cardiovascular system, the renal system. Everything gets slowed down except the GIT during sleep. The GIT is more active during sleep. That is why they say that a good sleep will help a refreshing in the morning, because all the systems will get regenerated and rebooted, so you are fresh the next day morning. So one of the features which you see in deep sleep is a decrease in the respiratory rate. Now what is cetograph? It's an outdated one. Nowadays nobody is seeing that. But just remember, for academic purpose, that cetograph is a graph which records the respiratory rate. Now this was the earlier method where a belt was tied across the abdomen, a graph was seen, and that will count the number of curves which are seen in the graph, and that is how you would come to know the respiratory rate. But practically speaking, the respiratory rate would be counted clinically on a bedside by seeing the movements of the respiration, by seeing the movements of the abdominal wall. So you make the person lie down on the side. Once you are making the person lie down, you will find that you count the abdominal movements, and when you count the abdominal movements up and down, you will find the respiratory rate per minute. So count the abdominal movements per minute and you will come to know about the respiratory rate. Now this is clinical significance, the respiratory rate and the heart rate. It is given as 1:4. That slide is a little bit wrong. I leave it to you and your intelligence to find out what is the mistake there. Now there is a correlation between the heart rate and the respiratory rate. The clinical significance I will tell you. We know that the heart pumps the blood. The respiratory rate involves in the exchange of gases. Now this correlation of heart rate and respiratory rate should be synchronous, so that there is an adequate oxygenation supplied to the cells. Oxygen reaches the cells. Now the heart rate is around 82 per minute. The respiratory rate is around, let us say, 72 per minute, and this is around 12 per minute. So that means that the ratio may be 4:1 or 6:1. So every 4 times the heart beats, 1 time there is a respiratory cycle, or for 1 respiratory cycle the heart beats 4 times. This is important because if this ratio is maintained, where for every breathing cycle 1 inspiration and expiration, if the respiration is for every 1 respiration the heart beats 4 times, then it means that sufficient oxygen is being transported to the cells. And this is important because tomorrow on the go, while you are passing on the road or in the swimming pool or anywhere, you find that there is a sudden person going into cardiac arrest. What do you mean by cardiac arrest? Cardiac arrest means that the heart suddenly stops beating. Now that means there is a cardiac arrest, the heart is not pumping, the oxygen transport is not taking place. So 2 things becomes important for you at that. You have to start the heart and you have to provide oxygen to it. So that is why you give a cardiac massage and a mouth-to-mouth breathing. So what you will do is, once to restart the heart, you have to put the hands on your heart. The palm of your hand should go onto the left side of the thoracic cavity and give a sudden pressure on the chest wall, so that when you are pressing the chest wall on the left side suddenly with both the forces, that is, you pump it on the heart, you are mechanically stimulating the heart, and you know that the muscle is a excitable tissue. It will start contracting again to any stimulus. If you remember, the stimulus I said can be a mechanical stimulus, can be electrical stimulus, can be chemical stimulus. So when you find a suddenly person dropping down and he is in a cardiac arrest, or in a ward a patient goes into a cardiac arrest, suddenly you have to immediately give a cardiac massage. So you have to press the heart. Once you press the heart repeatedly, the heart will get stimulated and the heart will regain its beat. So the heart will restart beating. But what about the breathing? If the heart starts and there is no oxygen, what is the use of a heart starting and there is no air supply or no oxygen supply? The person will still be brain dead and the heart will continue to beat. So you have to synchronously also see that once you are giving a cardiac massage, you also gives a mouth-to-mouth breathing. So for every cardiac massage, once you have thumb down on the heart, go to the mouth end, open the mouth of the patient, put your mouth on the mouth, put your lips or mouth on the mouth of the patient, blow in air forcibly one time. So once you do that, you are providing oxygen through mouth-to-mouth breathing. Beat the heart 4 times, it will stimulate the heart. Still not started, go back to the mouth again, do a mouth-to-mouth breathing, give one puff of air or blow one puff of air into the mouth, come back on this side and give a cardiac massage. So, or if 2 of you are there, one takes over the cardiac massage, one does the mouth-to-mouth breathing, so in the ratio of 4. So for every one single bout of mouth-to-mouth breathing, 4 times the heart has to be breathed, has to be pumped, so that if it starts, that is the ratio it has to be maintained. That is the clinical significance here. Next, events of respiration. I have told you earlier, the inspiration, there is expiration, and the duration of each respiratory cycle is somewhere around, let us say, 5 seconds. 4 to 5 seconds. So the whole process of inspiration and expiration is somewhere around 4 seconds. In this, the inspiration duration of inspiration is 1 second, the duration of expiration is 3 seconds. Now the next question will be, why is the duration of expiration a longer time than the inspiration? What does it mean? That means the inspiration is an active process, whereas expiration is a passive process. And the total duration of one breathing cycle is around 4 seconds. Now, when it is an active process, that means it requires energy. So remember, duration of inspiration 1 second, it is an active process, it involves energy, hence it is very short and happens very fast, whereas expiration is a passive process, it does not require any energy, so it takes a little longer time. So in entry of air into the alveoli from the atmosphere is inspiration, duration is 1 second and it is an active process. Expiration is flow of air from the alveoli back into the atmosphere and it is a passive process and it requires around 3 seconds. Now muscles of respiration. Now this basically will be covered by the anatomy. I will just go through the slide here. The muscles of inspiration normally is basically the diaphragm is the main muscle of inspiration and the other supporting muscles are the intercostal muscles. Now a brief word on the diaphragm. A diaphragm is a dome-shaped structure. This dome-shaped muscle will separate the abdominal cavity from the thoracic cavity and it is attached on 3 ends. Basically, anteriorly it is attached to the sternum, that is the xiphisternum, lower part of the sternum, and to the lowest ribs it is attached, and posteriorly the posterior fibers are also attached to the spinal cord. So basically the diaphragm is a dome-shaped structure, 2 domes on 2 sides, and the whole of this cavity is separated into upper thoracic cavity and the lower abdominal cavity. The innervation of the diaphragm is by the phrenic nerve. The root value of the phrenic nerve is C6, C7, C8, C9. In addition to this, you will find that the intercostal muscles are also the muscles of inspiration and they aid the diaphragm in breathing. Accessory muscles. What are accessory muscles? Accessory muscles are those muscles which do not take part in normal inspiration but take part only in distressed breathing or when there is a respiratory distress. So in asthmatics, in smokers, you will find that the accessory muscles are taking part in breathing. And what are the accessory muscles? The neck muscles, that is the sternocleidomastoid. You will find the scalenus muscle and the ala nasal. So if you closely observe an asthmatic patient or a smoker, you will also observe that not only his chest wall moves, but also you will find the neck muscles also become prominent. The ala nasal muscle, that is the muscles of the nose, the nostrils also will open up and will contract during breathing. That is the first clinical sign that the accessory muscles of respiration, accessory muscles are being brought for inspiration, and you can clinically suggest that the person is going in respiratory distress or there is a labored breathing or a forced breathing. Now this is the diaphragm. Here if you see, this is the diaphragm, this is the dome of the diaphragm, these are the lungs, and it is separating this diaphragm is separating the abdominal cavity from the thoracic cavity. Now this is the diaphragm. You will see that the green mark, I will just explain to you in the diagrammatically, and then I will explain. The green line is the normal position of the diaphragm. This is the attachment of the diaphragm, the two diaphragm this side and that side supplied by the phrenic nerve. This is the red line is the diaphragm which moves during inspiration. So the green line is normal when the person is not breathing. Not breathing, I mean to say at the end of inspiration, at the end of expiration, at the beginning of expiration. Then once the inspiration starts, you will find this, the red line, it is stretching downwards. So there is a downward movement of the diaphragm. Now what I mean to say here is the diaphragm is attached anteriorly to the sternum onto the lower end of the ribs and also on the posteriorly. When the diaphragm contracts, as it contracts, see the red line, it descends down. When this diaphragm contracts, it descends down. When it descends down, the thoracic cavity increases. Now compare the height of that green one. This is the lungs, right lung and the left lung. The green part is the area at the end of expiration or just before inspiration. So first step of inspiration, the diaphragm contracts. When the diaphragm contracts, it pulls itself down. When it pulls itself down, you will find that the volume of the thoracic cavity is increasing. So the first step in inspiration is contraction of the diaphragm, increasing the thoracic cavity, and you will find that the vertical diameter of the thoracic cavity is increased. So this cavity is increased. The vertical diameter of the thoracic cavity is increased. Now next, see what are the external intercostals. These are the two ribs and these are the first rib and the rib below. In between you will find that the intercostal muscles are attached. Here there is a diagram. These are the two ribs here. In between these two ribs you will find that the intercostal muscles are attached. This is the vertebrae posteriorly and it is coming in front, and here you will find it is the xiphisternum, and this gap between these two ribs is by means of the intercostal muscles. I think there is one diagram here. So now here you see. Now along with the diaphragm, when the external intercostals contract, what are they doing? They are pulling the rib cage upwards and forwards. So the whole thoracic cavity, if this is the thoracic cavity, it is moving forward and upward. So when it moves upward, see the red line and the black line. So this is at the end of expiration. Once inspiration begins, the external intercostals contract. When they contract, you find that they are moving upward and forward. When the chest wall moves upwards and forwards, you will find that the transverse diameter of the thoracic cage is increasing. You can also note, just take a deep breath and put your hand on the chest, and you see the chest hand will move forward and upward. So when it is moving forward and upward, what is happening? The transverse diameter of the chest wall is increasing. So the anterior posterior diameter is increasing. So with the contraction of this, you will find that the anterior posterior diameter is increasing. At the same time, you will find that the lateral aspect, the sides of the chest wall, this is the anterior posterior diameter. The sides are also lifted upwards and outwards. When the side walls are also lifted, this is the side walls. They are also lifted upwards and outwards. You will find that the transverse diameter is increased. So now I will explain the whole thing. The diaphragm and the intercostal muscles are the muscles of inspiration. When the diaphragm contracts, it pulls itself downwards. The vertical diameter is increased. When the external intercostals are contracting, the anterior posterior diameter is increased because the sternum is lifted upwards and outwards. At the sides, the lateral part moves outwards. So the transverse diameter is increased. So once the transverse diameter is increased, you will find that because of the diaphragm and the external intercostal, all the three diameters are increased. The vertical diameter is increased. The anterior posterior diameter is increased. The transverse diameter is increased. This is also called as a buccal handle movement, where you will find that the buccal is moving upwards, so the anterior posterior diameter is also increasing. Sidewards also it is increasing. So once the three diameters are increasing, the lung volume, the capacity of the lungs is increasing. When the capacity of the lungs is increasing, air moves from the atmosphere into the alveoli and inspiration happens. Now what happens during expiration? Now it is a process of expiration. It's a passive process where no energy is involved. Now what is it? Once the inspiration is happening, the alveoli are stretched, the elastic forces in the alveoli are stretched, the costal cartilages are stretched. Now once the inspiration over, the diaphragms relax and the intercostals relax, the external intercostals relax. When they relax, the diameter comes back to normal. Now the diaphragm is coming back upwards. The vertical diameter is decreasing. The external intercostals relax because the contraction is over. Now the external intercostals are relaxing. So the transverse, they come back to their original position. So the anterior posterior diameter and the transverse diameter also comes down. Now when it comes down, it causes a compression on the chest wall. Because of this compression, you will find that the air now moves from the alveoli into the atmosphere. Now the accessory muscles, what are the accessory muscles? The accessory muscles are those muscles which normally do not take part in expiration, but just they take part in expiration whenever there is a distress breathing, whenever there is a lung obstruction, like in asthmatics there is a spasm. So normally passive process is not able to expel the air out, so you have to force the breathing out. When you force the breathing out, you will find that the accessory muscles are helping or aiding this expiration process. So normally the expiration is a passive process, but once there is an obstruction or something, the accessory muscles comes into picture. So this is the diagram here where the green line indicates the diaphragm moves downwards, the vertical diameter increases during inspiration. After once air enters, the diaphragm relaxes, it goes back up. When it goes back up, the vertical diameter decreases. These are the intercostal muscles. Once they contract, they increase the anterior posterior diameter. So these movements are called as the buccal handle movements and the pump handle movements. The buccal handle movement is something like a handle where you find that handle of a bucket. When you stretch the bucket out, handle of the bucket, spread it laterally outward, you will find that the transverse movement is increasing. Whereas pump handle movement, you move the pump handle up and down, the anterior posterior diameter is increasing. So all the three diameters are increasing. So the lung cavity space is increased, the alveolar volume is increased. When the alveolar volume is increased, you will find that air enters and it is inspiration. For expiration, all this reverse process takes place. The diaphragm relaxes, the intercostal muscles relaxes, they go back to their original shape, the diaphragm ascends upwards and the compression on the thoracic cavity on the alveoli occurs, and as a result of air, which the air moves out. Now what happens to a newborn? Let us see how does a newborn breathe. Now we know that at the end of once the child has been delivered, the first process to happen or the first thing to happen is that we all are anxious as parents to see the first cry of the child. Why it becomes the important is because once the child cries, it means that the breathing has been initiated. It is the only instance where the cry of the child makes the parents happy. So why is that cry important? What is the physiological basis for that cry? I will tell you. Now, as long as the fetus of the child, the fetus is inside during the 9 months of pregnancy, the alveoli are well developed, and although they are well developed also, they are collapsed, they do not take part in breathing because the supply of oxygen, the removal of carbon dioxide from the fetal lungs is through the placental circulation. But now, such collapsed alveoli, when the child is delivered, as the child is getting delivered through the birth canal, the pressure of the uterine contraction will force the water accumulated in the alveoli or squeeze the water in the alveoli out. Now, as this has happened, and once the child is delivered, the obstetrician will first clamp the umbilical cord or cut the connection between the placenta and the child. Once this connection is cut, what are you cutting off? Cutting of the placental, clamping up of the placenta umbilical cord means that the blood supply from the maternal circulation to the fetus is cut. When that is cut, the oxygen supply is cut. When the oxygen supply is cut, there is lack of oxygen in the child, hypoxia is occurring. This hypoxia will stimulate the respiratory center. The respiratory center will now get stimulated. It will send signals down through the phrenic nerve to the diaphragm, through the intercostal nerves, for the diaphragm to contract, for the external intercostals to contract, and when they contract, the alveoli expand, and when they expand, the air gushes inside, and that makes the child cry, which becomes very important to all of us, the first cry of the child. That is how the cry is initiated, and once that cry is initiated, that means air has entered to alveoli, and once oxygen has entered into the alveoli, oxygen supply is restored and the exchange of gases continues, and the child then keeps on crying, crying and crying. So with that, the more the stronger the cry, the more the expansion of the alveoli, and the readily the exchange of gases is taking place. So this is the significance of the first cry of the newborn, or in other words, how the respiration is initiated in the newborn, and why it is important that this cry should occur within the first 3 minutes. If any delayed cry is there, or if the child does not cry, that means the alveoli are not expanding. If the alveoli are not expanding, oxygen is not entering into the alveoli, there is a hypoxia, and within 5 to 7 minutes, if supplemental oxygen is not given, there is a possibility of brain damage. Now, till now we have seen the mechanics of breathing. Let us see the pressure mechanics. What are the pressure mechanics which are taking place here? What is the pressure which is helping in this exchange of gases? Now, there are 2-3 things you have to understand here. First, I will explain to you what are the pressures involved here. Now, to briefly sum up what I have just told you. There is a contraction of the diaphragm, contraction of the external intercostals. There is an alveolar volume increasing. When the alveoli are increasing, that means what size of the alveoli are increasing, there is an increase in the pressure which is happening. So remember the volume and the pressure formula from your physics. At the beginning of inspiration, the diaphragm is contracting, the external intercostals are contracting. This is pulling the alveoli, the size of the alveoli are increasing. Once the volume of the alveoli increases, the pressure in the alveoli falls. And when the pressure in the alveoli falls, the atmosphere, it becomes less than the atmospheric pressure. The atmospheric pressure of oxygen is more. So 760 mmHg is the atmospheric pressure, and there is a gradient created from the atmosphere into the alveoli. Air enters from a high pressure area into a low pressure area, so that oxygen goes, or air enters from the atmosphere into the alveoli. Now, once the inspiration is over, expiration takes place. The diaphragm is being pushed up, the external intercostals are relaxing. The pressure now goes above the atmospheric pressure here, and because the pressure in the alveoli is above the atmospheric pressure, you will find that a reverse pressure gradient is created, where this reverse pressure gradient means that the high pressure in the alveoli and low pressure in the atmosphere, so the air now moves from the alveoli into the atmosphere and expiration is completed. So this is the pressure mechanics which is taking place. Now you have to understand here the two things here. One, this white one is the alveolar membrane or the respiratory membrane. The blue one which you are seeing here is the pleural membrane. Now, there is a covering which is present here between the alveoli and the pleura. It is known as the pleural membrane, and this pleura is of two types, the parietal pleura and the visceral pleura. The parietal pleura is the outer covering and the visceral pleura is the inner covering. Between the two pleura there is a space which is known as a pleural space, and the fluid which is present is known as the pleural fluid, and the pressure which is there is known as the pleural pressure. The pressure which is generated in the alveoli is known as the alveolar pressure. The difference between the pleural pressure and the alveolar pressure is known as the transpulmonary pressure. So, three pressures you should know. The pressure which is present in the alveoli is the alveolar pressure. The pressure which is present between the visceral pleura and the parietal pleura is the pleural intrapleural pressure, and the difference between the intrapleural pressure and the alveolar pressure, or the difference of the pressure which is across these two, is known as the transpulmonary pressure. Now here, during resting condition, the pleural pressure is negative 0.5 centimeter, minus 5 centimeters of water. During inspiration, it increases to around minus 8 centimeters of water. Whereas in resting condition, the alveolar pressure is 0 centimeters. Inspiration, it is minus 1, and during expiration, it is 1 centimeter. Remember these values. I will explain to you this little later. Now here it is the pressure volume changes during the expiration. Now, we know that the whole of the lungs are covered by pleura, parietal pleura, pulmonary pleura. There is a pleural pressure and there is a alveolar pressure inside. Under normal condition, you will find that the pleural pressure or pulmonary pressure is in par with the atmospheric pressure. Now, inspiration is taking place. The thoracic cavity is expanding. When the thoracic cavity is expanding, it is pulling the visceral pleura along with it. So the gap between the visceral pleura and the parietal pleura is increasing. So there is a negative pressure in the pleural space. So the intrapleural pressure, which is normally minus 2.5 centimeters or minus 1 centimeter, falls down further and it goes up to around minus 8 mmHg. So till minus 5 or minus 8 centimeters the pleural pressure falls. Once the pressure in the pleura becomes negative, it transmits the negative pressure onto the alveoli, as a result of which the alveoli expand. So the more the negative pleural pressure, more the expansion of the alveoli. When more the expansion of the alveoli, the alveolar pressure falls less than the atmospheric pressure. If the atmospheric pressure is around 760 mm, it falls down to somewhere around 755 mm, and as a result of which a gradient is created from the atmosphere into the alveoli, where the air in the oxygen in the atmospheric pressure is 760, the pressure in the alveoli is around, the alveolar pressure is 755, a gradient is created, so air moves from a high pressure area to a low pressure area. Now the inspiration is over, the muscles are relaxing. Now the pressure within the pleural pressure, which was going down to minus 8.5 mmHg, goes up little, becomes little less negative. So when it becomes less negative, the expansion of the alveoli is reduced. When the expansion of the alveoli is reduced, the alveoli shrink. When the alveoli shrink, it means that the alveolar pressure is increasing. The alveolar pressure goes up to 762 or 763 mmHg. The atmospheric pressure is 760. So a reverse gradient is created where there is high pressure in the alveoli, low pressure in the atmosphere. So the carbon air moves from the alveoli into the atmosphere, carrying carbon dioxide with it. The same thing is depicted here, where you find here, you see, this is the first graph, is the volume change. This is the inspiration part. This is the expiration part. See, this is the pleural pressure. If the pleural pressure is somewhere around minus 5 mmHg, because of the contraction of the diaphragm and the intercostals, the pleural pressure is coming down. As the pleural pressure is becoming more negative, the alveolar pressure, which is just 0, also falls down, becomes less than the atmospheric pressure, as a result of which a gradient is created. air enters and the alveolar volume increases. So the amount of air in the alveoli increases during inspiration. So this is the tidal volume. Assuming it is 0 at the beginning of inspiration, by the time the whole of inspiration is over, the tidal volume of 500 ml is reached. So here 500 ml of air is present. Now after 1 second the expiration begins. In the next 3 seconds expiration will happen. What will happen in the next 3 seconds? The diaphragm will relax, the external intercostals will relax. When they relax, they coil up, and the chest wall is elastic, the cartilages are elastic, they will recoil. So when they recoil, they will pull it back, as a result of which what will happen? The pleural pressure, which was going down to -8, now will come back to -6, -5, and in fact become nearly normal. So this transpulmonary pressure falls, as a result of which you will find that the expansion of the alveoli which are there is no more there. The alveoli tend to collapse. Remember that the alveoli are balloon. As long as you keep the balloon inflated or put air inside, it is inflated. Once you release it, it collapses. As it collapses, it increases the pressure in the alveoli. The alveolar pressure goes above the atmospheric pressure, and from here you will find that the air starts coming out of the alveoli into the atmosphere. So by the end of expiration, you will find that whatever air, the tidal volume 500 ml was air in, has also gone down. So here these are the markers: increase, a fall in the alveolar pressure, a fall in the pleural pressure, increasing the tidal volume to 500 ml. Here inspiration stop, expiration begins, the pleural pressure becomes less negative, the alveolar pressure becomes more positive, then the positive means becomes more than the atmospheric pressure, then the expiration starts, air is blown out of the alveoli into the atmosphere. So these are the volume and the pressure changes that takes place during breathing. Now let us see another thing is surfactant. We will see two other things: compliance and surfactant. Two important things which we will discuss here is, one is the compliance and the other is regarding the surfactant. Now, till now we have seen the mechanics of breathing, how air is entering from the atmosphere and leaving out from the alveoli into the atmosphere. Now, what are the other factors which are responsible for this transfer of gases to take place? One is compliance and the other is the surface tension. Now, you should know one thing here, that there are two things concerned with the whole of the lungs. The alveoli are composed of two things. One, the elastic tissue or the elastic fibers, and the other is the collagen. In addition to this whole of the chest wall is enclosed under the costal cartilages covered by the ribs. In between the ribs you have got the intercostal muscles and you have got the cartilage. All this is elastic in nature. The elastin has the property in the alveoli in the respiratory membrane, two structures are present. One is the elastic fibers and the other is the collagen. The property of the elastic fibers of the alveoli is something where it causes the lungs to stretch, stretchability of the lungs. So the elastic tissue is responsible for the stretchability of the lungs, or something like a balloon, where you blow air into a balloon it stretches, or you pull a rubber band, it stretches. Once you leave that pressure or you release that pressure, it recoils back. So also two factors are responsible in the alveoli. Elastin is responsible for stretching of the alveoli. The collagen is responsible for the recoil of the lungs. Two opposing forces are taking place here. Two opposing factors are played. During inspiration, the elastin fibers help the lung to stretch, whereas during expiration, the recoil of the lungs leads to coming back or collapse of the lungs. So now, during breathing, these two processes are taking place. One, there is a stretchability of the lung. Second, there is a collapse of the lung. This ability of the lungs to distend or to expand is called as the compliance of the lungs. So for a lung to stretch or the alveoli to expand, it has to overcome the collapsing tendency of the alveoli because the collagen fibers are always tending for the alveoli to collapse. So whenever you are breathing in air, you are overcoming the tendency of the collapsibility of the lungs, and the recoil of the lungs is overcome, then the alveoli are stretched. Remember this, it is very important. The alveoli have the ability to stretch. When they are stretching, the elastic tissue present there is allowing it to stretch, plus the collagen fibers which is there always causes the lungs to collapse. So whenever the collagen is there, it causes to collapse, and once the stretchability is lost, the elastic fibers will also contract. So there is a collapsing tendency of the alveoli. Now what is compliance? Compliance means the ability of the lungs to expand, or distensibility of the lungs is called as compliance of the lungs. So to have a stretching of the lungs or to distension of the lungs of the alveoli, it has to overcome the collapsing nature of the alveoli, and that nature is called as the compliance of the lungs. So compliance of lung is defined as the stretchability of the lungs. Now what determines this elasticity or the ability of the lungs to stretch? The more the elastic tissue, the more is the ability of the lung to stretch. So that elasticity or distensibility depends upon two things. One, the surface tension and the elastic amount of the elastic forces or the elastin or the collagen forces present in the lung tissue. Now this is the diagram where you will find that here, as there is a change in the pleural pressure, inspiration takes place. This is the curve. Change in the pleural pressure, the volume is increasing. Then as the pressure is falling down, becoming less negative, exhalation takes place. Now this expansion of the lungs, if you see this graph, as it falls from -4 to -8, for a huge change in pressure is required for the lung volume to increase. Read this graph purely on a statistical basis. For the lung volume to increase, let us say from 0 to 100, the pressure has to fall from -4 to -8. But once, let's say -6, but within a very narrow change, there is an increase in the lung volume. So the initial, for a greater change in the pressure, less air is entering. In the later half, for a very less change in the pressure, there is a huge increase in the lung volume of the alveoli. So this is called as a hysteresis loop, and this hysteresis loop is because there is initially a increased change in the pressure for a small increase in the volume. Later on the curve is very steep. The curve is very steep because for a small change in pressure there is an increase in the volume. Why is this happening? Why is the loop not steep from the beginning, but why it has to have a hysteresis on its nature? That is because the initial change in the pleural pressure, that is when the pleural pressure is falling down from -4 to -8, this change in the pressure is used to expand the alveoli to overcome the transpulmonary pressure. So the initial change in the pressure from -4 to, let's say, -6 is just helping for the elastic forces to expand, overcoming the recoil tendency. Hence very little air enters. Once that is overcome, a small change in the pressure will cause a great increase in the lung volume. So this is the hysteresis loop. So what is the elastic force determined? One, by the elastic tissue present in the lungs, and second is the surface tension. Now what is the static compliance? Now compliance is also defined as a change in the unit volume for change in the unit pressure. Delta V by delta P. That means a unit change in volume for a unit change in pressure. So the rule is whenever there is a change in 1 centimeter mm pressure, the lung volume changes by 200 ml. So for every 1 degree fall in the pressure, the change in the volume is around 200 ml. So that is a normal compliance. So what do we mean by normal compliance? Normal compliance is for 1 centimeter water change in pressure, the lungs should expand by 200 ml. Should expand by 200 ml. That means 200 ml of air should be accommodated. If there is a change in 200 mm, 2 centimeters change of pressure, 400 ml. So the normal change is for minus or 2.5 mm change in the pleural pressure, 500 ml of air can be accommodated. This is the unit change in the unit pressure. So if this is happening, the normal lung volumes or the lung elasticity is normal. If this is not happening, the compliance gets altered. That means either there is a defect in the change in the pressure or the exchange of gases is not taking place. The compliance is of two types. One is the static compliance and the other is the dynamic compliance. The static compliance is the change which is recorded when the person is static. You change 1 mmHg of pressure, see the change in volume. But dynamic is the change in the volume in the change in pressure for every 0.1 centimeter change in the pressure. That is called as dynamic compliance. So we have got a static compliance, a dynamic compliance. The next thing is on what factors does the compliance depends. Now the lung compliance depends upon 3 to 4 factors. One, the distensibility of the lungs. That means the ability of the lungs to expand. And what factors depends what factors does the dispensability depend? The distensibility depends upon the elastic nature. More the elastic fibers in the alveoli, more will be the distensibility. Less the elastic fibers, less will be the distensibility. And where does this happen? In smokers. In smokers you will find that there is a replacement of the elastic tissue by fibrous tissue. That is why their alveoli are less distensible, so their compliance is less. The other thing where the compliance depends is the elastic recoil. As I said, all this is elastic cartilage. There is a elastic tissue which has got a recoil tendency. Collagen fibers are present in the alveolar membrane which has a recoil tendency. The chest wall has got a recoil tendency. When the chest muscles are expanding, they are recoiling. The costal cartilages are recoiling. So all these recoil tendencies are causing the affecting the compliance of the lungs. Greater the elastic recoil, the less will be the compliance of the lungs. Suppose if this recoil tendency is converted or this elastic tissue, collagen tissue is converted into a fibrous tissue. So fibrous tissue doesn't expand, doesn't contract. So more the amount of fibrous tissue, less will be the collapsing tendency, more will be the work of breathing. Then it also depends upon the lung volumes. The compliance of the lung will also depends on lung volumes. Now within the lung, suppose if we are seeing in a sitting position, the lung has got an apex and a base. The volume of air at the apex is different from the volume of air at the base because of the effect of gravity. Now see the whole chest wall from here to here, if it is somewhere around 20 centimeters, the effect of gravity will be different at different points in the lungs. If you are standing in an erect position, the effect of gravity at the base of the lungs will be definitely different from the effect of gravity at the apex of the lungs. So at the apex of the lungs, the effect of gravity will be more, whereas at the base of the lungs, the effect of gravity will be less. So there will be a difference in the pleural pressure at the base of the lungs and at the apex of the lungs. So when there is a difference in the pleural pressure in an upright position at the base and at the lung volumes will be different. So this is the point which I am saying. At apex of the lungs, the distensibility will be different, whereas at the base of the lungs it will be different, and this is because of the gravity. So difference in volumes will also be seen just because of the effect of gravity. And when you are in standing position or sitting position, you lie down, there is no difference in the effect of gravity at the apex of the lungs or at the base of the lungs. So there will be no difference at all because of the effect of gravity. At that point, the lung volumes will be same all throughout, whereas when you are in standing or sitting position, the lungs change in the lungs will be more at the base of the lungs. The base of the lungs will expand more because at the base the lung expansion is less because the effect of gravity is less, whereas at the apex of the lungs the alveoli will not expand much because the effects of gravity will be more. The difference in the pleural pressure will be less pronounced there. Then also it depends upon the size of the lung. A one lung person is having a different compliance, two lungs person will have a different compliance, and damage to the lung will change the compliance issues. Then lastly, the compliance of lungs will also depend upon the surface tension. Now, what do you mean by surface tension? Now, this is something which you have learned about surface tension in your 11th and 12th class. Now, what does surface tension means? The surface tension is the tension which is present at an interface. The example is keeping the water molecules in a raindrop together. There is a tension at that liquid air interface, and all the raindrop molecules are held together because of the tension at the surface, and they tend to keep all the water molecules attracted. So at the air water interface, similarly, you will find that a drop of water, there is a surface tension because the surface tension is keeping all the water molecules bounded together. Now, let's go back and use the surface tension principle in our alveoli. What is happening at the alveolar level? In the lungs, you will find that there is an air which is present. You know that there is a water layer which is lining the alveolar membrane. A thin layer of water is always lined at the alveolar membrane, on the alveolar membrane. So there is an air-water interface. Now, because of this air-water interface, you will find that the water molecules which are lining the respiratory membrane, just adjoining to the air which is present in the alveoli, will try to keep the lungs collapsed. So surface tension on the alveoli is because of the water molecule which is spread out along the whole of the respiratory membrane, and this surface tension of the water molecule is trying to keep the alveoli collapsed. So there will always be a tendency for the alveoli to collapse. What are we trying to do? The body is trying to expand the alveoli. So once the body is trying to expand the alveoli on one hand, the surface tension which is present on the alveolar membrane because of the air-water interface is trying to collapse the alveoli. So two opposing factors are happening. The alveoli is trying, the water molecules in the alveoli are keeping the lung collapsed, whereas the body elastic fibers are trying to expand the alveoli so that there is an entry of air into the alveoli. Now let us see one diagram here where there is a comparison between the air water. This is the alveoli and this is an alveoli filled with saline only. I think this will help you to understand it better. Now see, this is the hysteresis loop which I was talking about. At 5 minus 4 mm of intrapleural pressure, there is no change in the lung volume. It falls up to minus 5 or minus 6 here. There is hardly any change or 100 ml of increase in the alveolar tidal volume. But from 0.6 minus 5 to minus 6, just a little bit of change in the pressure here here, you will find that the lung volume is increasing. So this is the hysteresis loop. In fact, it should be a little more wider and then the steepness, and this explains the effort of inspiration taken. Now coming on to the next slide here regarding the saline and the air-filled interface. Now this is also an alveoli, and in this alveoli there is no air present. There is only a saline which is present. Now you see a slight change in the pressure here is when a lungs or a saline filled alveoli is causing it to expand so rapidly that the volume changes from 0 to 0.5, that is to 500 ml. A slight change in the pressure is sufficient to increase the volume of the alveoli from 0 to 500. See on the other hand the graph. Here you will find that the pressure has to come from 0 to -5 and then -6 and -8 for the lung volume to increase from 0 to 500 ml. So this is a comparison between an air-filled alveoli and a saline-filled alveoli. What does it indicate? It indicates that just because when the alveoli are filled only with water, there is no air present, you will find that a slight change in the pressure is sufficient to expand the alveoli. Whereas when there is an air-water interface, where there is a surface tension acting, because of the surface tension of the water molecules or the forces attracting on the water molecules, it is trying to keep the lung collapse. So a great change in pressure is required from 0 to -6 for the alveoli to fill or stretch from 0 to 500 ml. That means what? If it is a saline filled alveoli, minimum work is required, whereas because of the water filled in the alveoli, because of the air, because of the surface tension and the water molecules present in the alveoli, there is an air-water interface, and this air-water interface is causing more work of breathing, because this surface tension acting by the surface tension exerted by the water molecules is causing the alveoli to collapse, and we need to increase the pressure. Active inspiration has to take place so that the lungs expand, overcoming the collapsing nature of the lungs due to the surface tension there. So that is the conclusion of the role of surface tension exerted by the water molecules on the respiratory membrane. Now, how do you reduce this work of breathing, or how do you reduce the surface tension? The surface tension can be reduced by means of a surfactant. So what is surfactant? This is a soap bubble model. I think you just leave it here. The surface tension is reduced by means of a surfactant. So surfactant is secreted by the alveolar membrane. It helps in reducing the surface tension, and surfactant is nothing but a surface tension reducing agent. Now what does this surface tension reducing agent does? The surface tension reducing agent will reduce the tension required at the air-water interface and reduce the work of breathing. So that is one of the functions of the surfactant. The surfactants help in reducing or overcoming the collapsing nature of the alveoli due to the water molecules. Now what is the composition of the surfactant? Now the surfactant basically is secreted by the type 2 alveolar cells. So here this is the respiratory membrane. Here there are type 1 cells. Normally there are both type of cells which might have been discussed yesterday. The type 1 cells and the type 2 cells. These type 2 cells are synthesizing the surfactant. The surfactant is stored by the endoplasmic reticulum in the form of lamellar bodies, and this surfactant is then secreted out from the type 2 cells into the respiratory membrane, and they spread all throughout the respiratory membrane. When they spread all throughout the respiratory membrane, they reduce the work of breathing. So surfactant is a surface tension reducing agent. It reduces the work of breathing, and it reduces the work of breathing by reducing the surface tension. It is secreted by the type 2 alveolar cells, type 2 alveolar pneumocytes. So that is the thing, reducing the surface area, it helps in easing the work of breathing. Now what factors are responsible for the secretion of this? Now the type 2 alveolar cells, The clinical importance. Now I am talking about the clinical importance. The type 2 alveolar cells secrete the surfactant only at the 34 or 35 weeks of the intrauterine life. That means during the 34 weeks, the surfactant is secreted. Before that, it is not secreted. That is why if there is a premature delivery, that is preterm infants, if they are born before 38 weeks, the surfactant would not be completely secreted. So once it is not completely secreted, the effort of breathing will be increased. The child will require more amount of effort to breathe normal air, that is for a tidal volume of 100 to 20, 10 to 20 ml, the respiratory rate should be 30 to 40 ml, but 30 to 40 times per minute. But because surfactant is not present there, so for that 10 ml of air also to enter, the respiratory rate has to increase. So the surfactant will increase the work of breathing and the rate of breathing, so they will go into a respiratory distress. This is called as hyaline membrane disease or infant respiratory distress syndrome. So that is why the delivery of the child is very important, should happen only at term. If it is preterm, for whatever reasons it is, it may lead to a hyaline membrane disease. Now, what factors are responsible for the synthesis of surfactant in the body? Not only the surfactant in preterm, but once the adults also, the surfactant is continuously secreted in the body so that it reduces the work of breathing. First is insulin. Hormones like insulin are responsible for increased surfactant synthesis. Any decrease in insulin will reduce the decrease of the synthesis of surfactant in the body. So there may be a respiratory distress. Even so, in diabetic mothers or diabetic pregnant women, it becomes important because there is a deficiency. Diabetes means there is less insulin. If there is less insulin in the mother's body, there will be definitely less synthesis of surfactant in the infants. So the infants may have a normal delivery, but there will be a chance of respiratory distress. In adults also, the insulin hormone plays an important role in increased synthesis of the surfactant. Second, glucocorticoids. Glucocorticoids are responsible for not only increasing the surfactant synthesis, but also increasing the surfactant receptors on the surface membrane. So, two things glucocorticoids play. One, they increase the synthesis of surfactant. Secondly, they increase the surfactant receptors on the cell membrane, on the respiratory membrane, so that the surfactant can bind there and it can act. And the role of the glucocorticoids is that this glucocorticoids, if there is a expected preterm delivery, the obstetricians will give injections of dexamethasone or corticosteroids. 48 hours high doses of steroids are given, so that this high doses of steroids, when they are given 2 to 3 days before the delivery, preterm delivery, expected preterm delivery, at least they will increase the surfactant synthesis so that the respiratory distress can be avoided in the newborn. If suppose a child is born also with infant respiratory distress syndrome, the treatment for it is they are giving nasal inhalations of the surfactant liquid. They are putting it on the oropharynx or the nasopharynx, from where that liquid or the surfactant gets absorbed into the lungs and thus reduces the work of breathing. So the respiratory distress can be avoided either by means of giving glucocorticoids injections in mothers before they are expecting a delivery, if it is expected to be a preterm delivery, or if a child is born with the infant respiratory distress syndrome, a surfactant is given directly in the nasopharynx so that it is absorbed and surface tension is reduced. The other thing is thyroxine also plays an important role in the synthesis of the surfactant. Smoking reduces the secretion of surfactant in adults. In addition to this, exercises, breathing exercises, yawning, sighing, all will increase the surfactant synthesis in the body. So these are some of the factors which are responsible for the normal secretion of surfactant. One, hormone wise, glucocorticoids, insulin, thyroxine, calcium, smoking, and then you have got this normal yawning, sighing, and deep breathing exercises which will help in the surfactant getting secreted. Now, the other thing is, what is the function, what is the composition of the surfactant? The surfactant consists of 90%, 60 to 70% of proteins and, cholesterol, lipids, 10% of proteins and a minimum amount of carbohydrates. So basically it consists of phospholipids and proteins. There are 4 proteins in it: SPA, SPB, SPC, SPD. SPA is the one which is responsible for reuptake of the surfactant after its use is over. SBC are helpful in maintaining the normal functioning. In addition to this, the SPA also helps in protecting immunity, it helps in immune booster, it helps in stimulating the immunity, local immunity within the respiratory tract. So first function of surfactant is that it helps in preventing the lung collapse. A person, by whenever has a normal secretion of surfactant, it reduces the lung collapse, it overcomes or it reduces the work of breathing, it gives stability to the alveoli. Now what do you mean by stability to the alveoli? Here if you see the diagram, I had explained to you a small alveoli and a large alveoli. So the surfactant, if you see the volume is inversely proportional to the pressure. So when there is a large volume of the alveoli, as it happens during the inspiration, the pressure is reduced, the role of surfactant is reduced. But once they are exhaling, the size of the alveoli comes down. When they are slowly coming down, the size of the alveoli comes down, the volume is reduced and the pressure is increased. There comes the role of surfactant in reducing the work of breathing, because from a small size alveoli, if you have to expand more and there is no surfactant acting when the size of the alveoli is small, you need to put more effort of breathing off for inspiration for the alveoli to expand. Therefore, the alveoli, the surfactant, when the volume is large or the lung volume is high, the role of surfactant is less because the pressure is less. When it is collapsed, the volume is less, the pressure is more, so the surfactant role in overcoming the work of breathing is more at low lung volumes than at high lung volumes. Then it also helps in preventing edema. The surfactant also helps to see that the proteins which are present there helps in preventing the pulmonary edema. It also helps in giving up immunity. So finally, 4 or 5 works of surfactant. First, it prevents lung collapse. Second, it gives alveolar stability. Third, it prevents lung edema. Fourth, it reduces. Lastly, the proteins which are present there will also help in giving some immunity to the respiratory tract. Now this is the airway resistance, where you will find that there is a resistance offered by anything when the resistance offered whenever air is passing through that is called as airway resistance. So the work of breathing involves, what is the work of breathing? When you are breathing in air and breathing out, there is a work of breathing involved, and this work is involved in doing what? It is overcoming the compliance, it is overcoming the tissue resistance. By tissue resistance I mean the costal cartilages and other tissues. Then there is an airway resistance work, where you have got the trachea, the bronchi, the bronchioles. Ultimately their resistance has to be overcome, because otherwise if you see in asthmatics, what is happening in asthmatic? There is a spasm of all these bronchioles and the alveoli. When there is a spasm, they become stiff and less expandable. When they become less expandable, the passage of air also becomes difficult. Then there is also work done to expand the thoracic cage. When you are breathing in air, as I said, the thoracic cage expands. When the thoracic cage expands, it is not only the external intercostals, but you have to overcome the costal cartilages which are present adjoining the sternum, attached to the ribs. So that also work has to be expanded. So these are the work done. Now what is dead space? Now dead space is something where the word says that space is dead. That means in breathing part, normally there should be an exchange of gases. If there is a place where there is no exchange of gases taking place, that is called as anatomical dead space. There are 2 dead spaces. One is anatomical dead space and when there is a physiological dead space. What is anatomical dead space? Anatomical dead space is the dead space present in the respiratory tract from the nose to the upper part of the bronchi, where air is present but no exchange of gases is taking place, and that is called as the anatomical dead space. So that is around 150 ml. So that out of 500 ml of tidal volume, when you breathe in air, it is 150 ml of the air which is present from the nose, the nasopharynx, the trachea, the bronchi and the bronchioles, where no exchange of gases is taking place. So that is around 150 ml. So ultimately, the exchange of gases is taking place only in the 350 ml which is present in the alveoli, because that is only capable of transferring the gases. What is physiological dead space? Now physiological dead space depends upon the ventilation perfusion ratio. I will tell you what is ventilation perfusion ratio, but here to understand physiological dead space means air is present and blood supply is also present, but there may be no exchange of gases taking place. So that is called as physiological dead space. So there are two spaces, anatomical dead space and physiological dead space. Then what is ventilation perfusion ratio? The word itself says ventilation perfusion ratio. The ratio between the amount of air entering in the alveoli and the amount of blood reaching that particular alveoli. So suppose there is one whole lung is present, 100 alveoli are present. There may be air in all those 100 alveoli during inspiration, but all those 100 alveoli should have the pulmonary capillaries around them so that exchange of gases takes place. If that ratio for 100 alveoli, 100 capillaries are present, then it is called as adequate ventilation perfusion ratio. There may be instances where the alveoli are present, air are present, but blood supply is not present. There the alveolar ventilation ratio will get reduced. That happens at the apex of the lungs. You know that the apex of the lungs is the top where air enters there, but because of the effect of gravity, the pulmonary circulation at the apex of the lung or the blood supply to the apex of the lungs is little less. So all the air cannot exchange the gases to the blood vessels there, so the ventilation perfusion ratio becomes less. Or at the base of the lungs where there may be more blood present but less alveoli because of the expansion difference, so that is also an altered ventilation perfusion ratio. Similarly, in smokers also you will find that the ventilation perfusion ratio is altered where it is more than 1. I will tell you, if in a lung there are 100 alveoli, because of the smoking effects, the alveolar wall between the two alveoli is destroyed. So there may be the space may be the same, but the number of alveoli are less or maybe less than 100 because the alveolar wall between the two alveoli is damaged. It is like two rooms you will have if you have one room in between. If that intervening wall is damaged, then the whole thing becomes single room. So also in smokers, there may be two walls are present, but because of the smoking, if the middle or the intervening wall is damaged, that means that there are now a single alveoli present where there is air present but no blood supply because the intervening wall is damaged, no transfer of gases takes place, and the alveolar ventilation is lost, there is more but perfusion is less. So there the ventilation perfusion ratio becomes more than 1, but it is of no use because there is no exchange of gases taking place. So this is about ventilation perfusion ratio. Here the diagram to show the anatomical dead space. Here it is from the nose, it is the trachea and the bronchioles. So from the nose till the bronchioles, it is the anatomical dead space. It is around 150 ml. Here air is present but no exchange of gases is taking place. This is the alveoli. Here this is the apex. Let us assume this is the apex of the space here, apex of the lung here. Here you will find that air is present but less of perfusion is taking place because only this much of perfusion is present. So this becomes the physiological dead space because there is a low blood flow. But here in the rest of the alveoli you will find that there is so much of blood flow present so that all the air can get transported, oxygen can go into the circulation and the exchange of gases can take place. So this is the normal ventilation perfusion ratio. Here the ventilation perfusion ratio gets altered. This is physiological dead space, there is anatomical dead space. Same thing I was talking of where it is more than one. In smoker, imagine one more diagram like this here, one more alveoli, but this wall gets damaged. When this wall gets damaged, so you will find that this intervening blood supply is also lost. So there is a one big alveoli here, but only this blood supply is there, no other blood supply is there. So complete exchange of gases cannot take place. The ventilation perfusion ratio becomes more than 1. Though air is entering, but no exchange of gases is taking place, it may result in hypoxia. Thank you once again. I request all of you to go back home and read this topic. It is very important. It is difficult to understand, especially the surface tension, the compliance of the lungs. You need to revise. If there are any doubts or you want some topic or subtopic to be repeated, just mail me across. We'll find time someday between 2 to 3. I'll inform you well in advance so that doubt we can have a doubt clearing session and I will clarify. Thank you one and all.